Secretary.
Thank you, my lady. Ms Pritchard, I want to examine with you this afternoon the build-up to Wave 2 and the winter 2020 to 21 pressures, and look at the Nightingales as well, and a couple of other discrete areas. So we've got quite a lot to get through. Can I start, please, with asking you about the lead-up to winter 2020? And in your statement at paragraph 630 onwards, you set out that in July of 2020, NHS England sought 10,000 non-temporary beds to deal with recovery and the potential future surges. And I think you go on to say in the statement that the request for the funding for those beds was not approved by Her Majesty's Treasury. No doubt something of a disappointment to you, but why was it felt at that stage in that summer that as many as 10,000 extra beds were going to be needed?
Thank you. We had done some modelling work over that summer to look at, again, recognising there was a huge range of possible scenarios, but just looking at from a sort of best estimate what it would take to be able to run with a sort of constant number of patients in the service who were COVID positive, create the necessary headroom then to respond to, as we were saying previously, normal winter pressures over above that, but crucially also to have the space to do the not just urgent but also non-urgent, non-COVID work, so that we would be able to do that recovery work that we'd begun to start in the summer.
And I think the Prime Minister's private office was involved in the decision to refuse and said effectively they wanted more use to be made of Nightingales, the independent sector, to go back to discharging patients if necessary, using flu vaccinations to hopefully deal with any flu upsurge there would be, and that there would be capacity would be looked at in the spending review, which I assume would be at the end of the financial year of 2021. Is that correct?
Yes, autumn 21.
What were the consequences of that 10,000 bed request being refused from your perspective?
It was, as you say, very disappointing, because what it meant in practice is that where we could now be in, I think, a very different position on elective recovery, if we had had that capacity, we could certainly have treated thousands more patients if we had had that additional headroom, as well as being more resilient going into the second wave and into winter more generally. So subsequent to the pandemic, there has been some steps taken to increase core bed capacity, but clearly we could have done with that capacity at the time, and I think we'd be in a quite different position now.
Does this might bring you to your paragraph 633 in your statement ending 251, Ms Pritchard, because you say that given the additional pressures faced during winter months, NHS England has reduced other investments to prioritise what are called marginal funds and capital to make available 4,000 extra permanent beds in the acute sector to increase capacity to deal with emergency care. Help me about this 4,000 beds. How does that fit in with the 10,000 refusal, if at all?
Yeah. So that's from January 2023, so leading into the financial year 23-24, as part of, again, the government-supported urgent emergency care recovery plan, which had a combination of a number of different actions, one of which was to increase acute bed core capacity, another of which was to increase virtual ward beds in the community. The impact of that investment and all of those different initiatives meant that last year, and I know it's something other witnesses have talked about, the pressure on ambulance services, but we did see ambulance response times for what's called Category 2 responses reduce from 50 minutes to 36 minutes. So it made a big difference last year, but of course that was some sort of, considerable period after we had asked for the 10,000 beds, which was at that early stage of the pandemic.
So if I understand you correctly, the 4,000 beds has had a positive effect since 2023 onwards, but back as at the time of the request in July 2020 was essentially NHS England reliant on discharges, Nightingales, surging within its own capacity to try and find additional beds in the event of a pandemic striking again in the winter, or re-emerging is perhaps a better way of putting it, in the winter.
Yes,
Right.
So we could foresee clearly that we were going to have to live with COVID for some considerable period of time, so that would create, if you like, a sort of ongoing pressure on the NHS, and we could see even back in July, and in fact, of course, had written about it in the phase 3 letter, that the recovery job would be hard. So those two things, the ability to continue to deal with further waves of COVID and the ability to deliver recovery would have been massively enabled by that investment.
Did you get any extra beds between July 2020 and the end of our relevant period in June 2022?
We did get some additional funding to support developments within critical care specifically, so about around about £250 million, which was invested partly in additional capacity, but partly in the fabric of the estate around critical care units to make them more robust, more resilient, to improve some of the environment.
Can I jump forward then in time to winter 2020 into 2021? And in your statement, you make clear that that was a period of extreme pressure on the NHS over that winter. And could we have a look on screen, please, just as a quick indication of it? 409-251_0134, your paragraph 501, Ms Pritchard. But here we are, as at New Year's Eve in 2020, there was 1,050 additional critical care beds had been opened, and national occupancy for critical care had passed 100% of the standard footprint. So baseline had been met. Is that correct? We were now into using up the surge capacity. 3% of critical care patients across the country were being cared for in surge capacity, but London, East of England, South East were particularly affected. They all had to use their surge. Look at London there, 28% critical care patients were in surge, 22% and 14% in the South and the East of England respectively. Critical care units in the East were at 100% capacity. In the Midlands, 21 critical care unoccupied beds across the entire region of the Midlands, and only 4 of the 28 units had less than 100% occupancy. Clearly, to try and deal with those pressures, regions were taking steps to facilitate intra-regional transfer to balance the load. For instance, moving patients from Cumbria to Newcastle in the northeast, and Kent was being actively decompressed by sending patients to Oxford. Now, Ms Pritchard, one takes the point that it's better to have a bed somewhere than nowhere, but Kent to Oxford is, 140 miles or so, 3 hours in a ambulance. We've heard that the fact of transfers themselves are risky for both the patient and the staff that have to care for them. Can you help us to how it is we ended up in such a dire state of affairs come New Year's Eve 2020 into January 2021?
Yes, thank you. I think there's, if you don't mind, there's sort of 3 things worth saying. One, about the preparations that we've been made, one about the wave 2 experience, and then one about specifically critical care. So firstly, it is community prevalence that drives what is going on. And of course, at this point in time, importantly, we did have community prevalence data, which we didn't have in wave 1. So at this point, when the community prevalence data starts showing that the numbers are going up, we have an early warning system which allows us to see where some of the peaks of pressure are likely to be geographically, because they happen at different times in different places, which becomes important when we're then thinking about critical care transfer. But fundamentally, it is not within the NHS's control what happens with the virus in the community, and therefore what the demand is made on the NHS. But because, sort of second point, we had foreseen that there might be a second wave, and indeed even back in August, I think our modelling even then was saying it was likely to be, if it did happen, at least as bad, at least as challenging as wave one. There were a number of things that we, NHS England and the NHS had done, as well as wider partners. So we've talked a bit about just that investment in critical care. Obviously, at this point, we have more ventilators. We have a more robust supply chain around things like PPE. We have the Nightingales on standby. We also have, at this point, about 50,000 more staff in the NHS, which is, as I said earlier, partly, extraordinary. Just contribution of people choosing not to retire, as well as people coming back, and also joining from overseas. We have the partnerships with the independent sector still live, and also at this point with the hospice sector, so we have access to additional beds through that route. But the crucial thing at this point is we also have new treatments, and we have a vaccine on the horizon. So we have dexamethasone, which has come out, I think we rolled it out, the new guidance in a day in July, because it made such a difference. And the vaccine, first vaccination, 6th of December. We have begun to do a bit of that recovery that I talked about, although not as much as we would have liked to be able to do if we'd had more capacity. And we do have staff testing at this point. So we go in to the second wave in a very different place to the way we went into the first wave. But as you say, and this is coming on to your specific point here, the level of community prevalence combined with the severity of the variant meant that in practice, the peak of demand on the NHS was actually considerably greater than it was in the first wave. So the whole approach to surge was to say the best thing for patients was to maximise the available capacity in situ before you then start to have to either move patients or to open new facilities such as the Nightingale. So at this point, what we're seeing is individual organisations absolutely hitting not just their sort of baseline capacity, but their surge capacity, triggering then local transfers, which are going on, I should say, they go on today. There will be patients being transferred between critical care units, but at a much greater volume at this point than anything you would normally see, and a systematic approach to cross-regional transfers. That is unusual. So to transfer patients anything like this distance, you would only do in a circumstance where clearly there was not the capacity locally to absorb the pressure. But partly because we have the early warning system, we could see at this point that there were parts of the country that were less badly affected. So it did mean that we could relieve some of those local pressures, but at the price of having to take patients some considerable distance at times.
I understand all of the things that are in place, but what may get lost there is the toll that wave one had taken on the ability of the staff to care in the same way that they did at the outset of the pandemic. And was there any plan in place for asking them again to redouble their efforts to try and deal with this January 2021 surge?
So in my experience, staff did not need to be asked to do the extraordinary things that they did throughout the pandemic. The thing that we were more concerned about was the health and wellbeing and safety of staff. So at this point, we have also rolled out, and again, I know you've heard from other witnesses on this, the risk assessment process for staff that are known at this point to be at greater risk. We've also put in a whole range of health and wellbeing offers nationally to support local staff. And actually, at this point, we're working with colleagues like Professor Fong, who I know you've heard from, to look particularly at the needs of critical care staff, because whilst there were enormous efforts made by all staff, critical care staff really were in the eye of the storm. So things like in the professional nurse advocate programme is born out of a particular concern for this group of staff, who are once again, without being asked, doing the most extraordinary things to try and make sure that they can provide care.
I want to pick up on something Professor Fong told us in a moment, but can I just ask you about CRITCON 4 declarations? Mm-hmm. Now, I appreciate, Ms Pritchard, that it's not coming from a clinician's perspective, but could we have up on screen, please, INQ 474 486_7? Ms Pritchard, the inquiry's seen this document before, but it is the CRITCON declarations across, thank you very much, across the relevant period. And if, with the assistance of the document handler, could we highlight the black, which is to represent CRITCON 4 declarations? They're very difficult to see. They run at the top of the screen. And remind ourselves that CRITCON 3 is described as being full stretch, and CRITCON 4 is described as being an emergency where resources are overwhelmed, possibility of triage by resource, or withdrawal of critical care due to resource limitation is being considered. And there's a little black during, I think it is the beginning of the pandemic in March, and then in the middle ringed section, we are between January and about April 2021. And could we just go back out and look at the document again? We've got the blacks there that are difficult to see, but if you look at that section from Jan 21 to April 2021, there's a significant amount of red, CRITCON 3 on there, notwithstanding the 4s. May I ask you this then? I know that we have a statement from Mr. Prentice, who sets out that some of the CRITCON 4 declarations may have been made in error, but at least 2 of them have not been made in error. And I just wanted to ask you, do you not think the fact that the hospital is declaring themselves at CRITCON 4, even if technically they're not, is an indication of the pressures that the NHS was under back in January to April 2021? Even just looking at the red, it tells us that, doesn't it?
Yes, so I actually think on this, it's an incredibly effective way of illustrating exactly the point you've just made, which is, and I guess I'm making as well, which is that wave 2, in many ways, was actually more challenging than wave, in other ways less, because of all the things we knew that we didn't have before, and obviously the hope of the vaccine. But in terms of what we actually saw of the peak of demand and the level of pressure, wave 2 was completely terrifying at times. So, I was talking to people who were in hospitals, in intensive care units, who were describing some of the same things you've heard from witness testimony, and and we were very close at times, very close. So the fact that there are so few blacks on your graph sort of do, I think, illustrate also what we were doing, which was when trusts were, and they were often getting to the peak where they were right on the edge, there was the ability, because of, I guess, the very small number of times we see it flip over to level 4, to be able to relieve the pressure in that local place, such that we didn't get to a position where there was widespread CRITCON 4, or indeed, what that really means, which is it means actively and systematically limiting care.
Right. So when you say we were very close or right on the edge, to use your words, does that mean running out of beds in any particular hospital and indeed region?
Yes.
Yeah. If I suggested to you we were on the brink at times in January 2021, would you disagree, Ms Pritchard?
No.
Now, in your statement, you made clear that there were 3 occasions where you were concerned that critical care would exceed capacity: February and March 2020, winter 2020 to 21, and indeed, you say in winter 21 to 22, because Omicron was a slightly unknown entity, certainly at the beginning, but in fact, clearly because you'd got increased people attending A&E, they having decreased in 2020, in fact, there was a real pressure in 21 to 22 as well. All right. Now, one thing you say in your statement, you say at your paragraph 484B, everyone who needed to be treated in a critical care bed had been given a critical care bed, but this precipitated a need for patient transfers between hospitals and regions to balance demand. And can I ask you, on what evidence is it that you rely to be able to make the assertion and claim that everyone who needed a critical care bed got it?
Yeah. So I think on reflection, it is a clumsy statement. It really is intended to make the point that I've already made, which is as a combination of having two things, which were hard data, which is partly what we're looking at on screen, as well as other data sources, but also crucially, that everyday conversation that is going on both through EPR and directly. We were aware nationally of where we were reaching that point of, absolutely maximum capacity locally, such that there was an ability then to relieve local pressure either through that local transfer or further afield, or indeed moving equipment, moving staff, to support those places that were really under maximum pressure, such that we never got to the point nationally where, if you like, the philosophy that we always had in the NHS through all of the pandemic, which was we try and treat every patient to the best possible within available resources, such that became impossible, and we were then talking about systematic limiting of access to treatment. That does not mean, though, that it did not feel completely overwhelming to staff at this time in those places. And it does not mean that the kind of care that was being provided was anything like normal. And it also, doesn't mean that this looked like sort of, in any way how you would think of as our sort of normal way of providing critical care services in particular.
It's not my intention to criticise any clumsy or slightly over-optimistic drafting, but you bring me to the point I wanted to make, which was the data tells us so much. One only needs to look in your statement, if anyone wants to, at pages 127, 128, 129, there clearly were some spare beds available throughout most of the pandemic, depending on which setting you're looking at. But the point that we have heard a number of witnesses say, it's not just about the bed, it's about the quality and the detail of care that is provided. And so do you think perhaps, Ms Pritchard, there was an over-reliance on the data presenting a rosier picture than actually was portrayed on the ground for those particularly in critical care units?
I'm confident in saying there wasn't for us. And in all of the conversations we were having with government, we were really clear about what people were actually experiencing. And certainly colleagues of mine were inviting in and making arrangements for journalists to film in our critical care units and in our hospitals to try and help the public understand what extraordinary lengths staff were going to. And I know we will have all seen colleagues at whether it was the daily press conferences or elsewhere knocking down systematically any suggestion that the NHS was not pulling out all the stops and under enormous pressure, actually not just in wave 2, but certainly wave 1 and other times as well.
Notwithstanding the acknowledgements you've made about the pressure on the NHS, do you accept that there were a proportion of people, it looks like, weren't in fact taken into critical care or ICU units? We heard, for example, from Cathy Rowan of ICNARC, who said potentially some of the data suggests that elderly patients were not being admitted into ICU. We also have had research conducted by the inquiry where a number of staff have spoken about difficulties in escalating people into critical care. So the assertion that we all got a bed if we needed it is only true to the extent if you were in it. But we've heard there's a great number of people being treated outside critical care that would have normally been treated within it. What can be done in the future to try and ensure that there is more critical care capacity in the event of a respiratory pandemic like COVID?
So I'm not saying for a moment that I can possibly speak for every clinical decision in every hospital. Obviously can't. But I think the bit we can do though is a combination of looking at what the data is telling us about what happened, what the lived experience was around trying to relieve pressure and transfers, and the logic of trying to surge locally, surge then regionally, surge nationally was the one that allowed the NHS to continue to function. What I think the data tells us from ICNAR, I've looked carefully at what Professor Rowan and Dr. Matteo have said, and I think they're right to be cautious about drawing conclusions, and certainly they're right, clearly, not to dismiss any of that data and what it might tell us, but in terms of being able to draw a direct causality, I think I would share their view that we'd have to be careful about jumping to conclusions, and clearly there's a need, I guess, to understand a bit more about what the therapeutic options around vaccination, dexamethasone, other forms of oxygen allowed to happen outside that traditional ICU space, which is also feeds into this. But what your question, which is about future resilience, I think probably goes back to some of what we were discussing earlier. Because a bed is not a bed. A bed is a physical space, yes, but it is only a bed if it's got staff, if it's got medicines, if it's got equipment, and all of those things are part of what I think forms that future resilience narrative and that future resilience ask, which clearly, well, I've already said we didn't have headroom going into the pandemic, and that has not materially changed as we stand now.
There's clearly decisions made about whether one gets into critical care or ICU. What about the actual level of care provided once in it? Professor Fong told us of a visit that he conducted at the end of December 2020, where he described the ICU unit as bursting at the seams, and he went on to outline the number of patients that were in ICU, in A&E and the emergency department waiting to get into ICU, a patient in an ambulance waiting to get into the hospital that died before he could even get into the hospital. And he said this: "It is genuinely the closest I have ever seen a hospital to a state of collapse in my entire career." Now, if one looks at the data, that is not, nor could it ever be, portrayed in the data.
No.
But do you think there is a real danger that NHSE over-relies on the data? And how do you think you can better understand the frontline pressures than perhaps had been in place during the pandemic?
I don't agree. Throughout the whole pandemic, there was a combination of information that we were relying on. Data was an important part, but it certainly wasn't all of it. So Professor Fong went out to do those visits partly at the request of my colleagues in the EPR team, because they valued so highly that first-hand feedback. Similarly, I have to say I was in the room with very senior politicians relaying exactly those kinds of stories and describing in a way that I think was very clear. In fact, we've got notes, I know were released through another module of the Cabinet Office discussions and meetings COVID-0 in January 21, with some of the language there I think clearly says we were very clear about the state of pressure in the NHS, and that was widely understood and well understood.
What plans are there in the event of a future pandemic to have something like the peer support programme that Professor Fong undertook? Is there anything like that is ready to go, as it were, in the event we need it again?
Yes, there's a set of things, particularly around supporting staff, which I think have been, if we were looking for learning, I would have liked to start with them rather than develop them through the pandemic. So it would have been very useful to have been able to switch them on sooner. And where it's been appropriate, we've maintained those. So things like the Professional Nurse Advocates Network still exists. We are doing at the moment a review of staff support, partly to make sure that we have properly and systematically looked at where national initiatives make the biggest difference and how they can most usefully support, what will always be primarily, local responsibility to support local staff, but absolutely relevant, absolutely right.
Do you think that looking at the quantitative data is not really sufficient for measuring the strain on critical care units?
Do you mean the CritCon data?
Yeah, CritCon data or any of the other. We've looked at we've got various sit reps that show us the pressures that the critical care units were under. Do you think that just doesn't accurately convey the strain on critical care units by just looking at the data itself?
Yeah, which is why we never would.
All right. Can I ask you about one other matter in relation to the data, and it's the way in which capacity in critical care units was communicated. And could I show on screen, please, INQ 474-255_22, and at the same time, if able, _39. And whilst that's being put up, Ms. Pritchard, we've heard from two intensivists, Professor Charlotte Stummers and Dr. Ganesh Sontharalingam, that in England, critical care bed occupancy is reported as a proportion of not only the existing capacity, but of the surge capacity. And to that extent, it is different from how the other nations report their capacity. And I've just put up on screen two of the graphs that we used when those experts gave evidence. And it's really this. I understand why NHS England would want to know how much of the surge there is left before you hit peak capacity. If we look at the figure on the right side of the screen, this was taken from Northwick Park. One can see that their baseline there, I think, was 22 beds. They were then operating considerably in excess of that throughout a lot of the pandemic. But there was some capacity, as represented by the grey boxes, that we can just about make out. But if you look at the 5th of April, it's almost all full. And they have exceeded at least double their usual baseline capacity. Scotland mark it differently. They had up to 575, I think it was odd, beds available, 175 normally. They just exceeded baseline capacity in sometime in March to April 2020. From the public's perspective, do you think that conveying capacity by reference to both baseline and surge perhaps misrepresented how truly bad it was for a hospital like Northwick Park to be running at over double their baseline?
So I think you've really importantly identified that data is used for different purposes. So the way that, I should say it was obviously just in the pandemic that it was done like this, but the way that the data was reported against maximum surge was for the operational purposes to identify when a unit was reaching its maximum capacity and therefore might need transfers or other support. So actually, you can see, as you rightly say, that happened a number of times over this period with Northwick Park. And bearing in mind, this is I think it's an 8 a.m. date stamp on this. Obviously, there will be more activity flowing in to a unit over the hours. So as a snapshot in time, I think the Northwick Park data, you would expect to see quite a high number of transfers with this kind of profile, because they're clearly showing that they're very near or indeed at or over capacity a lot of the time. So from an operational perspective, that's the important thing to know. From a does the public understand from the data only, then I think it's a very sensible suggestion to say both putting in kind of baseline and surge probably makes that clearer. But I suppose that's where what I'd come back to is we certainly would never rely, certainly in our communication with government, our internal decision making, or the way that my colleagues were talking to the public and the opportunity they did have on only data telling the story. And really importantly, things like having some incredibly brave journalists actually going in and spending time in units reporting from them directly, I suspect told a much more powerful story than data alone.
In the event of a future pandemic, what are NHS England's plans for the way it communicates ICU capacity? Is it going to do baseline and surge, or revert to the way Scotland does it? Are you able to help?
I can say I don't think we've actually formally concluded what the right answer would be. I suspect the inquiry will have a view, but my personal view would be that in order to make sure we're doing the both and of reporting the data that's operationally most useful, but also telling a sort of a clearer story with the data, the both and would be a sensible way of doing it.
You don't want to scare people off from going to ICU, because that comes with it a whole different set of, or attending A&E certainly, a different set of difficulties. But certainly the public perception may have been that it looked like there was more capacity than in fact it was, because they would have been running at staffing ratios of way in excess of 1-to-1 by the time they were dealing with 50, 60 patients in their ICU.
I think you're right that the balance is really important, because if I take a step back again, we were really anxious that people were not coming forward for care. And actually there was a survey done early on which said 1 in 10 people, if they had a new lump, a new mole, wouldn't bother the health service with it, even if it didn't go away. And just looking at the number of people who didn't come to A&E, that was an increasing concern as the pandemic went on. But I think your point about both and hopefully would allow a reassurance on the operational view that there still was capacity to treat people, along with those messages, strong messages about please come forward if you need help, whilst also avoiding any misunderstanding about the level of pressure that the NHS was under.
May I change topic completely, please, Ms Pritchard, and turn to Nightingales? And I think you set that out, if it helps you, at pages 259 onwards in your statement ending 251. But you set out there that as at about the 20th of March, so just before we went into lockdown, it was felt that London might be the first to be hit with the real effects of the pandemic. Modelling suggested that 4,000 beds might be needed when London had 800 at that time, and that it was over the weekend of the 21st to 22nd of March that the Nightingales were conceived. And were you involved in the conception of the Nightingale units? Were you in meetings that weekend discussing this?
I was in meetings the entirety of that weekend, yes.
All right. You say there that Nightingales were conceived. Inherent in the Nightingale assumption was that they would be, quote, right-sized to enable flexibility regarding staffing models and be able to be built at speed. What did you mean by right-sized?
So at the time, if I go back to that period, as you say, the data was telling us on the reasonable worst-case scenario, and really crucially, the doubling rate of the number of patients who were in hospital, because, I mean, just some simple maths on 2, 4, 8, 16, 32, you get a lot of people very fast. And at that time, we were actually modelling a double rate of 3 days. Now, it wasn't as bad as that. It actually ended up being more like 5 to 6 days. But the rate of increase meant we did not think at this point that there was going to be a scenario where they would not be needed. So we thought we were building something that we would have to open, and really fast.
and I think you say that on the 23rd of March, you, Sir Simon, and a number of other officials attended a meeting with the Prime Minister, Matt Hancock, and other government ministers and officials. And I think essentially there the go-ahead was given to be able to start the Nightingale programme, starting with, I think, the Excel Centre in London, but at the same time, recognition that there would need to be Nightingales across all the other regions of NHS England. All right. Now, to help you, and I hope Her Ladyship, can I have up on screen, please, INQ 474444, which is a schedule of the Nightingales, when they were approved, when they became operational, the activity that they saw during Wave 1, the activity they saw during Wave 2, and indeed the setup, running, and decommissioning costs. And I should say we're grateful to those who represent you for their help in preparing this schedule. If one takes London as a starting point, it was approved, as we just looked at, on the 23rd of March. It went operational on the 3rd of April. But during Wave 1, 57 patients were admitted. It was open for admissions from April to May 2020, then on standby. And during Wave 2, it was not used to admit COVID-19 patients, but 71 non-COVID-19 patients were treated. And we can see there that from the 11th of Jan 21, it was used as a mass COVID-19 vaccination centre until late June 2021. Set up 77 million, 49 million to run, just over 5 million to decommission, total cost 132 million. And I'm not going to go through each and every different Nightingale, but to take a different example, slightly later, Harrogate, approved 15th, set up 6 days later. It was opened on standby. No patients were admitted. As the region managed within its existing capacity, it was able to be reactivated to admit patients within 7 days. And then it sets out there how, in fact, it ended up being used because it had clinical imaging equipment and it was able to provide CT scans. Again, it was ready to be used in Wave 2. Total costs 32 million. Exeter was the last. May I ask you about Birmingham, though? 10th of April it was approved, operational on the 16th, on standby, no patients admitted. And again, no patients admitted in Wave 2, nor indeed any other indication that it provided vaccinations or imaging or stand-down facilities for those who were seeking rehab at a cost of 50 million. I suspect you know what I'm going to ask, but at a grand total of 358 and nearly £500,000, do you think, Ms Pritchard, that that was a useful resource that was available to the NHS, albeit one that was very little used to treat COVID-19 patients?
Yes. Yes is a simple answer. And let me tell you why I say that. And it's because when we were at the beginning of this process, making decisions about opening these unprecedented field hospitals, because that's what we're talking about, we went into this, and I think you've heard from Simon Ball from Birmingham about this as well, expecting to need them, because we didn't have community prevalence data. We only had the data which was the rearview mirror about patients who were in hospital at the time. So it was much more uncertain than it became later on when we could predict much more accurately what was likely to happen. But the doubling rates looked like we were going to be in a situation where we would hit the kind of maximum operational, even with the surge that we've talked about, capacity. And if we had not had this kind of facility available at that time, this inquiry would be having a very different kind of conversation if we had ended up in that kind of scenario where we would have been unable to treat potentially many thousands of patients. So at the time, and I think just worth saying perhaps that date of approval on this chart is the date of the formal assurance approval. The actual decision date was that early conversation that we've talked about with the Prime Minister, because obviously this again is a government decision that we're then operationalising. And actually the formal decision on the later ones, with the exception of Exeter, is the 1st of April. So these are the sign-off of the assurance processes. So at that point, when the wave is still going up, and we don't know where it's going to end at that point. So the first wave is, in lots of ways, I'm back to the sort of, it was terrifying. It was really, it's those moments like that weekend where I was in the London office with loads of clinical colleagues and others, and we thought we were about to do something that we'd seen in China, where they opened field hospitals, and we thought we were doing it to avoid a Northern Italy situation. So the fact that we didn't actually need to open them at scale in the first wave was a source of huge relief. Some of them, as you say, were open. So London opened actually slightly ahead of where it would have. So they were designed, London specifically, was designed only really to be used once every other bit of capacity had been exhausted. So we were assuming at this point everywhere would be working at a 1-to-6 ratio, from trained staff to other staff, so 1-to-1 from a staffing point of view, but not from a specialist skill point of view. And when London opened, we were not at that point, but the clinicians, rightly, in my view, thought it would be safer to open it a bit earlier, to have a sort of couple of weeks of trying to test it out before potentially it would then have to be opened at the sort of scale that we were looking at that time. And in fact, of course, that never happened, so it never had to be opened at that kind of scale.
Pausing there, I take your point, as you say, this was a contingency we never wanted to use.
Yeah.
Thankfully, you would say never had to use, or certainly not in the way it was envisaged. But how was it envisaged it was going to staff it? If you take London as an example, they're already operating at ratios of 1-to-6. Who was going to staff the Nightingale if we needed it for COVID-19 patients?
Well, so thankfully, London wasn't, nowhere was at 1-to-6 for any extended period of time. But the guidance had said that is where, thinking about surge and how you would step up, the guidance gave a kind of clear, if you like, sort of permission cover to do that. Some places, I should be clear, again, did hit those sorts of ratios for short periods of time, but certainly 1-to-4. What we saw that in a number of places. So, but other places didn't have to get that far. What that model, I know you've talked to Dame Ruth about this, but that model had a model where there would be one specialist nurse looking after effectively a group of patients, with then other less experienced, less skilled members of staff from other clinical fields supporting that, and groups of volunteers. So for London, for example, we had made plans to train airline staff who were at that time available and keen to help to be part of that volunteer workforce. But you would not have reached the point of opening a Nightingale theoretically, certainly in London's case, although, as I say, it did open a bit earlier as a test or an early trial, I guess, unless everywhere had got to that extremist level, and it never did. So we never needed to get to that place.
I know, but that comes back to the question I was asking, was who was going to staff it then, had we got to that level?
So that would have freed up. So if everywhere was running at a 1-to-6, that would have allowed staff both to be released to support the Nightingale, but also that's where the volunteers become crucial. And even in this very early phase of thinking about London, it was clear that there were parts of the country that were under less pressure. So it would have been difficult to move staff from other parts of the country, but actually there were hotel facilities that had been secured as part of the model for London, such that people could have been accommodated if we had reached that point. But your substantive point is right, that this is, if we had hit this point, then I think we would have reached that point where it would have been unrecognisable for the kind of care even that was provided during that first wave.
So if I follow you right, we would have had such significant dilutions in the hospital within their own surge, breaking out into operating theatres, repurposing other wards, and then you would have had significant dilution of care in the Nightingales as well.
Yes, so the Nightingale model was a military field hospital model. So we had military colleagues, invaluable military colleagues working with us throughout the whole of the pandemic, but particularly supporting the Nightingale project. And it was part of their thinking, how do you do this in a real live situation, that informed the staffing models and indeed the whole approach to Nightingales. But it might be worth saying that I talked about that date of approval was this sort of formal assurance, and the formal assurance process included the sign-off of plans and plans for staffing and the staffing model.
We have heard evidence, though, from both Professor Fong and indeed Dr. Santharalingam that the devil in intensive care is in the detail. And once you dilute the detail, you're actually providing a different form of care, was how Dr. Santharalingam put it. Or as Professor Fong, once you start diluting the detail, it kind of stops being intensive care, is what he said. There may be no easy answer to this, but would you advocate for the establishment of Nightingales again if we had a pandemic like we did back in March 2020?
So I would start, I think, honestly, with you wouldn't want to rule that out before you knew exactly what the circumstances were of a further pandemic. But this is a what's the alternative question. So we had done surge, this is super surge. So this would have meant, again, you're absolutely right. This is not critical care as we understand it. This would be something, this is field hospital medicine. And the alternative is that you do not treat people at all.
I see that Exeter didn't have to be decommissioned because it was used for other purposes. If you were planning for any future disaster on the scale of this pandemic, what about a system whereby you spent a lot of money, many millions of pounds, but then you could repurpose the unit thereafter there are all sorts of things. I've heard about elective hubs and that kind of thing.
Yes.
Is there any thought going into whether that would be an option? Yeah. So in other words, you hadn't wasted the 300 and whatever million.
Well, I think I would. I
take back the word wasted.
Well, yes, thank you.
You would say properly prepared. Sorry,
yes.
You haven't spent it without needing it.
Yeah. So that's right. And on cost, I know it's perhaps just worth thinking. And again, it's an illustration of these were not normal hospitals, because a normal bed costs to build, and a modular bed costs about £500,000. And actually, this works out across all of the beds that we opened, sort of as in spent the money on being able to open, would have been more like 88,000 per bed. So they're not comparable, as in they're not the same, and I think that illustrates the point. But Exeter, because it was later, they were able to work with their local partners to identify a building that could be kept. So as a model for the future, that's very different to the conference centre. Clearly, the Excel want it back. So I would definitely agree with you, my lady, that the Exeter model has huge advantages, because it was both big and at scale to do what was needed potentially, or what we thought would be needed at the time, but has been able to be massively useful for the recovery effort longer term.
Before I leave this spreadsheet, Birmingham is something of an outlier in that it didn't receive any patients in wave 1 or wave 2, or on the basis of the information we've set out here, be repurposed for another use. Why, do you know, was Birmingham not used to do something in wave 2 for standing down patients, being used as a vaccination hub? What was the particular problem that meant 50 million was spent on a facility that was never used at all?
Yeah, so each of these, having visited all of them, each of them was in a very different, had very different physical constraints. Actually, one of the things that we haven't talked about was that it was the difference between the sort of wave 1 model of care and the wave 2 model of care, because one of the things that happened between the two was absolutely where it was whether physical building meant it was possible to be used for other purposes, whether that was CT scanning or day cases, or indeed in Exeter's case, they also used it for training nurses, for example, training overseas nurses. That happened, but they were also adapted so that in wave 2 the model of care would have been different, because wave 1, given what we were looking at the time, had to be done really fast. By the time we got to wave 2, there was sufficient greater knowledge about the virus and how it worked to know that you would really not want to ventilate patients in a field hospital. You would absolutely want to keep them on a hospital site, hence the model of transfer and national transfer if required. So they were remodelled to be much more step-down facilities, but not step-down in the sense of people waiting to be discharged from hospital, because putting a frail older person in an open plan environment with no privacy and limited access to bathrooms is clearly not appropriate. But in Manchester's case, it was a good example of where it was adapted to be a genuinely helpful resource, I think, for them to be able to relieve pressure from an intensive care perspective so that they could then bring more patients through. So for Birmingham, and I know, again, you've taken evidence from Simon Ball on this, Birmingham actually stretched the capacity within the hospital site for intensive care, such that they took enormous numbers of patients from their local area, but actually more widely across the Midlands. And that was so they didn't need to use their facility for intensive care because they had stretched the capacity within their own site, which was a much better model of care for patients. And the physical facility just didn't lend itself to being adapted for other purposes in the way that some of the others did for wave 2 and beyond.
One of the things you say in your statement is there was a concern, certainly initially, that the Nightingales would not have enough ventilators to treat the anticipated number of COVID patients. Now, I appreciate that at the beginning everyone thought everyone would need a ventilator, and as it turns out, COVID is a multi-organ disease. So we've got that in mind. But can I just ask you about ventilators? You said this in your statement, that it was for the trust to purchase their own ventilators, so there was no central inventory at the start of the pandemic as to how many ventilators there was. And what I'd like to know is there such a central inventory now?
The short answer to your question is there is not, but there are plans to create one. So NHS supply chain is currently working on an asset register. They're prioritising diagnostic equipment like CT and MRI, but next year the plan is that would then expand to include equipment like ventilators. In this case, there had been an exercise in 2017 to do a sort of rapid piece of work around ventilator capacity. So there was a baseline which was broadly right, actually, going into the pandemic. It was repeated as a quick exercise in February 2020, and I think it's just. I absolutely agree an asset register is a sensible thing to have, but I still think if we were in a similar situation, you would want to do that stock take again anyway, because part of what was happening on the ground in February is, clinicians, as they were telling me about, were literally taking kit out of cupboards, testing it, saying, well, what if we attach this to it and that to it? Could you repurpose it for this? So you'd still, I think, need to do that sort of real-time testing to see what kind of stretch capability and what state some of that equipment was in.
Your statement sets out in great detail the efforts made to increase ventilator capacity for CPAP and the like. And I think it gets to the position that by certainly September, there was over 31,400 mechanical ventilators, I should say, in September 2020, when we had started out with significantly less than that at the beginning of the pandemic. I suppose what I want to know is what's happened to the additional ventilators that were managed to be sourced, and how ready are they to be wheeled out again in the event of a future respiratory pandemic?
The story on ventilators, I think, is both success story of rapid procurement and manufacture, but also a sort of important caution about what lends itself to stockpiling and what doesn't, because ventilators, unlike PPE, have parts that degrade. So actually, keeping a stockpile is a different task to, say, PPE, where there's a constant call-off of PPE that's then brought into use, and then it's replaced by new stuff. So you have a kind of constant rolling ability to keep a live stockpile. With ventilators, that doesn't quite work, because they would need maintenance, and they would need to be constantly replenished with some of the parts that would degrade. So there was a ventilator stock held by the Department of Health. I believe that has now closed, and those that were able to be usefully used were distributed. Some that were purchased, I think, in the early days in particular, for to a specification that actually wouldn't be the one that you would want to use on an ongoing basis. So I know some of those, or I believe actually, because it doesn't sit with us, it sits with the department, but I believe some of those you wouldn't have wanted to bring into normal use anyway.
Can I move from equipment to people? Because one of the things you said before lunch was to tell us about the absence rate of staff, and in particular due to anxiety, stress and depression. And I think you set out in your statement that NHS England established a workforce cell in March 2020 to support and mitigate what was thought was likely to be a 20 to 30% absent rate across its workforce. Was that because taking into account COVID-related absences as well as stress, other illnesses and the like? Where was the 20-30% absence rate come from? Excuse me.
Yes, thank you. So that was a piece of modelling work based on the reasonable worst case scenarios that was specifically COVID related. So it was a total sickness number, but driven predominantly by some assumptions about what was happening with the virus.
And you say in your statement at paragraph 858, if it helps you, Ms Pritchard, that the NHS does not use a single staffing computer system across all settings. Gathering consistent and reliable data required a bespoke SITREP to be established, which essentially then began to tell you how many staff were absent on the previous day across all settings. That SITREP being established, what did NHS England do once armed with the data about the people that were absent from work the day before? How did it help?
So I think it was useful in a number of ways. One goes back to the point we've been discussing about a bed is not a bed if it hasn't got staff. So if we were thinking about what's creating pressure on the NHS, that workforce data was a really important part of understanding what was going on locally, along with all the other things we've talked about. It was also important in the early days when we had really limited access to tests. So being able to identify places that were hotspots, where they had outbreaks for targeting support with staff testing, that sort of thing was useful. The other thing that was valuable was really being able to identify, again, where we were seeing pressure points that meant you would just go and ask, what can we do to support? So some of that led into the people working with our cell lead in particular on the health and wellbeing programme.
So when you say it enabled people to go out and say, well, NHS England to say to you, what can we do to help you? What kind of responses were being given? I appreciate they might want 10 more staff on a given day. Putting sort of the practicalities of adding some more bodies into the mix, what else was being relayed to you as the ways in which NHS England could help where there was significant episodes of absence?
So, yeah. So in the early days, testing was a really big ask. So we had lots of completely understandable requirements. or desire for access to staff testing, particularly where there were high levels of absence. So that was one of the things we worked really closely with Public Health England, as well as with our own sort of subcell on testing, to try and make sure if there as and when capacity became available, it was targeted most effectively. One of the big asks, which was later, was really about access to asymptomatic staff testing, which came in November with lateral flow. Other things that were asked at the time, there was a really, again, important request around risk assessment for staff and support with that, and with appropriate frameworks for redeployment and for reasonable adjustments for staff who were at a greater personal risk from the pandemic. And then there were a range of things, as I recall, thinking back, where I think it was a bit more specific. So, for example, my recollection is there was a request from Filipino staff for some targeted and more bespoke bereavement support, because that was something that they've been particularly at the front line of dealing with. So everything from, if you like, the sort of very much, this is for that, might have heard it from particular groups of staff, but it was relevant to the whole NHS, and then others that were a bit more specific to particular staff groups or particular places.
You told us that, generally speaking, even pre-pandemic, there was a high proportion of sickness absence due to anxiety, stress, depression and other psychiatric illness. It spiked then, I think, in July 2020, where there was 32% of absences due to anxiety and stress, depression, before it dropped back to 23% in 2022 to 2023. It's still a significant proportion, Ms Pritchard, of the workforce off due to anxiety, stress or depression. One can understand why it peaked as it did in July 2020, everyone having just gone through wave one, but now in 2022, 2023, back down at 23%. What is in place to try and support staff and try and mitigate as best you can the effects of stress, anxiety, burnout, depression, when those staff are on the front line trying to deal with the pandemic?
Yeah, I mean, so we had so I'm trying to think, I know this is one of the things you've talked to other witnesses about, so forgive me if I don't have as comprehensive a response, but my recollection is that because we had an expert advisory group that was chaired by Carol Black, and had a range of other really, really knowledgeable and insightful people, we were hearing a clear story, which was that the emphasis had to be on, if you like, supporting local employers to support their own staff, because that was all the evidence says that's the most powerful and the most helpful thing you can do. So one of the things we asked was that everybody had health and wellbeing conversations with line managers in place, and then that was rolled out with health and wellbeing champions to oversee that, and board level support. So that was one big area of focus, was how do we as NHS England set the guidance, set the expectation, provide the right support for local leaders to do the things that are going to be most impactful. But I think their advice was that there was also some ways in which nationally we could supplement what was available locally in a way that would be helpful. So, for example, the mental health hubs that were set up during the pandemic were specifically in response to the point you've made about staff experiencing high levels of mental ill health, stress, anxiety as a result of what they had experienced in the pandemic, as well as other factors. And things like the helplines that we put in, some of which were targeted to particular staff groups. The website had over 1 million uses, 1 million views. So a whole range of things that were particularly designed to support that local offer.
And finally, this then, in the event of a future pandemic, is there any sort of planning for how to support NHS staff to try and reduce or minimise the number of people that are off sick with the stress, the depression, the anxiety?
Yes, I think the staff treatment access review that's going on at the moment is really about occupational health services and what again are the sort of so we tried lots of things in the pandemic, and we tried them at pace. One of the things that we did through the sort of 2 years was to constantly try and reflect on what was working, what the feedback was, iterate, change, a bit like we've talked about with the Nightingales. But I think now in the sort of beyond when we've got the ability to just step back and reflect properly. Actually, the reason we've chosen to do this more formal review around health and wellbeing support and what the national support could best be for local delivery, as well as looking at what the occupational health offer of the future could look like, is because I think there is a recognition that there is no doubt things that could be better now, as well as things that we would want to have in place for a future pandemic.
Do you think the NHS workforce is more resilient now, less resilient now? Where are we at as at 2024?
So on the one hand, we do have more staff now than we did going into the pandemic, so 70,000 more staff. So numbers-wise, we have more, which is fantastic. From a how do staff actually feel and the level of resilience to even think about having to do anything like this again, I would say there is a long recovery journey ahead.
Ms. Carey.
Thank you, my lady. Ms Pritchard, can we turn to some lessons learned and recommendations, please? And I think you can confirm that in June of 2023, NHS England published a nearly 150-page document of lessons learned from COVID-19. I'm not going to go through, nor does time allow me to do so, all of them, but I would like to ask some discrete matters. In that document, you make the point in relation to, or I should say NHS England makes the point, that effective ventilation and air quality is important in NHS buildings. And the report says that lessons have been learnt during the pandemic have led to additional guidance being published relating to ultraviolet devices for air cleaning and HEPA filters, as indeed we've got in Dorland House here. And I'm particularly keen to know about what more, if anything, is being done to improve ventilation in the older estate. Can you help with that at all?
Yes, you're right to point to the challenge with the existing estate rather than the obvious opportunity with new estate. At the moment, we've got a estates maintenance backlog of, I think, now approaching 14 billion. So the works to improve ventilation sort of by necessity will have to line up with a number of other competing demands on the capital budget. Where there are remedial works to existing trusts, I was talking to a colleague who runs a trust that has had to do quite a lot of work on their maternity unit. That is an obvious opportunity to then take into consideration those guidance, those updated HCM guidance and instructions, in fact, about what the estate needs to look like. So where those opportunities arise, it is being considered as part of that work. But what we do not have is a ability at the moment to do a comprehensive review of all of the existing estate with a view to bringing the existing estate up to that standard. However, clearly the guidance does talk about those opportunities to use devices like HEPA filters, UV devices, where the estate is not good enough to be able to meet the ventilation requirements. So that would clearly be part of a future pandemic plan.
I think you said this morning that the backlog as at 2019 into 2020 stood at 9 billion. And do I understand now it's got worse to the tune of 5 billion as a result of the pandemic and no doubt just the age and wear and tear. Right. All right. So the backlog has got worse, making it all the more problematic for you to deal with. how does that feed into the resilience or otherwise of the estate in the event that we had a pandemic next year? It sounds like we're in a worse position.
So, yeah, they are two slightly different things in the sense that the estate backlog points to a whole number of things that aren't necessarily about ventilation, single rooms, etc. But your fundamental point is right. The estate is ageing, and every year that we are not renewing it, it's getting older. And old estate is not just inefficient; it was also much less adaptable and less able to be brought up to the standards that we would now recognise as the standards you would be building into new build.
Different topic, please. We know that there were a number of deaths of healthcare workers during the pandemic, and there is concern about the ways in which it's recorded. But I'd just like to ask, from NHS England's perspective, you set out that there was, as you entered the pandemic, no systematic national mechanism to capture staff deaths. And in the Lessons Learned report, and it's at page 93 for anyone who wishes to look at it, you say that there is work done at national, regional and local organisation levels that provides a foundation to build upon should this be needed in future pandemics or other emergencies. Can you help us briefly, if you can, with what work has been done to help reliably capture the number of deaths of healthcare workers?
Yes. So the process was set up, as you say, from scratch at the beginning of the pandemic, and was a sort of parallel process with two different ways of reporting. That was streamlined mid-pandemic to be a single way of doing it, and it's been further reviewed and strengthened more recently. But so that's the positive. Something exists. It has been reviewed. There's a version of it now which I think is more robust, more resilient than we had before. The tricky bit is always a combination of both kind of individual sort of data protection, privacy arrangements around how exactly you would use data in a way that was appropriate about individuals. The way that we in NHS England kind of dealt with that was to make sure that any reported death was validated by an employer or by a CCG if it was a colleague in primary care. And I know that there have been some concerns that has underreported the data because the other the ONS source looks at death certificates where somebody is identified as a healthcare worker. Obviously, that's harder to validate because one of the things that we put in place was a set of criteria, including how recently you were actually at work, whether you were there in a voluntary capacity, which is included in the data, or you were an outsourced member of staff, also included in the data. But really understanding what the discrepancy is between the sort of what we can validate by those official sources versus what's the self-reported, I think does remain an outstanding area, and part of the review that's happened has been to look at that, but I think that still hasn't been satisfactorily resolved.
Does the review look at whether the data will capture the ethnicity of a healthcare worker that has died?
I don't know, but the way it was reported during the pandemic did, so I imagine it would, but I can get back to you on that.
NHS England in July of this year published a framework for managing the response to pandemic disease, and no doubt that would be your blueprint if there were a pandemic in the next reasonably foreseeable future. It is identifies the issues, but if I may put it like this, it might be said that it's light on concrete proposals as how to achieve better leadership, better staffing resilience, better data capture, all the things we've been talking about. Is there any other work that's going on to do a, for example, respiratory virus pandemic plan as opposed to a bloodborne virus pandemic plan?
So to be clear, I mean, clearly we felt it was really important to have both a continuous process of lessons learned and a way of updating the framework as we went along. My expectation is that that will be further iterated and developed depending the outcome and advice of the inquiry. But you're quite right, having something ready to go, should there be a more immediate need, felt important. So one of the things that the EPR framework does, as it currently stands, and I've unfortunately had the experience of actually being on the other side of this in a number of major incidents back in my previous roles as well, is it sets a framework for you to make decisions depending on the specific circumstance you find yourself in. So, for example, a major incident in a trust, it doesn't try and say what happens if it's a train versus a car versus a plane landing on Heathrow, but it gives you the right questions to ask, the structures to use, and, if you like, the sort of signposts for here's where we've learned stuff in the past, this is what you would want to go to and pull from to help you make decisions in this specific circumstance. So as it stands at the moment, the EPR framework, we would expect that to remain an overarching pandemic framework, but then be able to signpost to the sorts of learning from, well, as we have in the past, for example, from MERS and SARS, which led to things like the HSID network, but also the learning from the most recent coronavirus pandemic, to be able to say, right, there's a set of things you would do in this circumstance, which might, as you say, be different if it was, say, bloodborne or something else.
Finally, this from your perspective as CEO, if there were a recommendation, one or two, that you would urge on her ladyship, what would they be that would genuinely help those on the front line in the event of a future pandemic?
Remembering the art of the possible.
Yes, thank you. So actually, one of the things that I would strongly say is the importance of the community prevalence data and the testing, so that we could properly understand what was going on with the virus and put the NHS locally as well as nationally in a position to be able to be front foot on response and better able to protect our staff, better able to understand what was actually likely to come over the next week, 2 weeks, 3 weeks beyond. Was absolutely critical, and it made such a difference going into the latter part of the pandemic that we had that. So maintaining that infrastructure and that ability to be able to respond then at pace with testing and community prevalence data, crucial. Probably unexpectedly, given my job is the NHS, but actually I would say don't forget social care. I know this inquiry won't, to be clear, but we can only do what we can do in the NHS if we've got an equally, if we've got that strong partnership with social care, so the staffing, the resourcing, all of the questions you've rightly asked me, I would say that would be a crucial underpinning for our resilience in any future pandemic. And then, if I was allowed a third, it is this resilience point. So, yes, buildings, equally staff, and actually the data infrastructure and our ability to do things like support remote working, that we have a strong community infrastructure that doesn't rely on having to pull people into physical buildings like hospitals, would be the other really big piece of the jigsaw for me for a future pandemic.
And that latter recommendation lies, is it not, with NHS England itself? I was conscious that prevalence data may come from UXA, as it now is, social care department, and I was thinking about what does NHS England want? Is it and can achieve? Is it the data yourself that you're responsible for?
Yes, so we do. So we've got things like the federated data platform, but we're supported enormously by things like the setting of standards for interoperability that mean that systems are designed to talk to each other rather than having to be sort of joined up through a third party. Some of the arrangements that we've also got in place now for things like virtual wards, and it's home monitoring, it's remote testing, it's all, not just for the virus, but for other things as well. So yes, absolutely plans in place, but continuing to make the investment in that technology and in the data infrastructure such that it's there when we need it next time, with the right policy wraparound, I think would be invaluable.
Lady, those are my questions. Thank you.
Thank you. Ms. Polachek, I don't know how much of your thunder Ms. Kerry's stolen.
A little, and I'll try not to repeat anything that the lady. I ask questions on behalf of clinically vulnerable families, and I'm just going to pick up on a couple of the points you were just making in respect of ventilation in the NHS estate. So Professor Beggs, who's the IPC expert to the inquiry, has set out a number of the challenges in relation to ventilation in the NHS. And one of the key issues he identifies is that the NHS Health Technical Memorandum, which I think you've just referred to earlier, that govern ventilation in healthcare facilities were written prior to the pandemic and are in what he calls an urgent need of updating. And for example, he notes that they fail to address the risk of airborne spread of COVID outside of specific high-risk environments, and they don't give any guidance on the use of HEPA filters. Do you accept, or does NHS England accept, that the HTM guidelines are out of date and need to be updated? And is there a plan for doing so?
Thank you. To be honest, I was a bit confused by that reflection from Professor Beggs, because the HTM was updated in June 21, and of the working group who were involved in that and the expert advisors, he was one of them. So I absolutely understand the point about HEPA filters and UV devices, and that's why subsequent they have been added to the HTM as two additional documents, but it's clear that the intention is you have to read the whole thing together. So I'm hopeful that we have actually done the thing that he was asking for, because that is that June 21 HTM plus the advice on HEPA filter devices and UV devices is now has now been thoroughly reviewed and in light of learning from the pandemic.
I don't want to speak too much for Professor Beggs, but I think the way he puts it in his report is that the additional notes on HEPA filters are what he describes as an add-on response, and so they aren't part of the mandatory guidance under the HTM, but that may be something that he has misunderstood.
I can certainly double-check that it is clear that that has to be read as a package. That is my understanding, is that now sits as a package of HTM plus those additional points.
Thank you, Ms. Pritchard. In respect specifically of HEPA filters, again, Professor Beggs described these as kind of the low-hanging fruit of fixing some of the ventilation problems. And as you've alluded to, of course, it is expensive to upgrade ventilation in the ageing NHS estate all at once. Aside from that guidance for forward-looking work, what work is being done currently to put in place more access to HEPA filters in the NHS estate?
I'm afraid I would need to probably get back to you with more specific feedback on that. As I said to Council a moment ago, what I am aware of is where there are works going on, where there's an opportunity to upgrade the ventilation of estate that is being taken, as well as you say, it being built into kind of future estate planning. On the specific use of devices, I mean, that guidance has now gone out. The expectation is that that is going to be then considered appropriately by estates and clinical professionals and used appropriately. But as I say, I would just need to come back with more information as to whether there's a sort of formalised programme around that, because I'm not aware of the detail.
Thank you. And just the final question, of course, accepting that there's a need for prioritisation of capital spending, we also know that clinically vulnerable patients face greater risks than others entering healthcare settings due to the impacts for them if they contract COVID-19. So in light of that, would you accept that there is an urgent need for those patients to make it safe for them to access healthcare now and in any future pandemic?
So absolutely understand the importance of us making sure that all patients are safe in NHS facilities of whatever kind. I think the sort of the reality, though, as you say, about just the level of backlog maintenance and the urgency of some of the pressure on the estate and the age of the estate does make it very hard. And you're making constant, risk-based decisions about what to spend money on locally, and is it, that concrete roof that's about to, or not about to, I'm exaggerating, sorry, but, where there's a risk that it might crack at any time, or this, where there's a water leak, or that where, there's another problem. So I would certainly absolutely agree that this needs to take its appropriate place within the prioritisation that is going on locally about how to spend the capital resource to upgrade the estate. But I think it is in the current environment, it is probably difficult to go much further than that.
Thank you, my lady. Those are my questions.
Thank you very much for your help. Mr. Wolfe, he's behind the pillar as far as you're concerned, I think.
Hello, Ms Pritchard. So I asked questions on behalf of John's campaign, Carers' Rights UK and the Patients Association. And the theme of my brief questions is the way in which NHS systems, by working with families involving in the care process, by talking to patients as well, can improve the outcomes for patients and their families and indeed for the NHS itself. So that's the context of the questions. My first questions are about patient experience departments, or sometimes called patient experience teams. Our view, John's campaign's view, is that involving them can be very helpful in helping to advocate for and create dialogue between patients and their families and the NHS. I imagine that's something you would agree with. It's not something you mention in your witness statement. Is there any significance in that?
There is no. I mean, my witness statement answered the Rule 9 questions given by the inquiry. So, no, I certainly wouldn't want you to read into that any more than that. It's absolutely my personal experience from having worked in the NHS for now many, many years that partnership with patients is invaluable when you're designing and delivering services.
One of our concerns is that the role of the patient experience teams appeared to diminish during the pandemic. Again, is that consistent with your experience and something that should be a matter of concern?
It's a good question. I mean, it's difficult. One of the themes of this discussion today, to some extent, has been, I think, what is the national and what is the local. So talking to colleagues who were more in the front line than I was during the pandemic, I think it's probably right to say there was variation, and there were certainly some teams that I think were really pulling in their patient experience teams to work with them, and certainly it's something we would encourage. But I think there were others where probably it's fair to say there were just other competing operational pressures that meant that perhaps didn't have the level of attention that it did elsewhere or could have done.
So in a future pandemic, you would want to encourage everyone, all the different providers and trusts, to follow that better practice of involving the patient teams?
Yes.
Different theme, if I may. A couple of paragraphs of your witness statement, paragraph 532 and 537, you talk about, and we completely agree with this, the way in which longer hospital stays can generally lead to worse health outcomes. One of the ways in which we see that can be mitigated is by the involvement of family carers in supporting the professional health teams. Again, is that something you would generally support?
Yes.
Then in terms of the position of discharge, you talk in paragraph 519 of your statement about the process of accelerated discharges in December 2021. One of the things that we think can support those kinds, well, any discharges, but particularly accelerated discharges, is a real focus on recognising the value that family carers provide in supporting the ongoing delivery of health once somebody returns home. Again, is that something you're supportive of?
Yes, completely. And I think all of the guidance on discharge, both within both issued in the pandemic and subsequently, reinforces the point that actually that joint, we've already mentioned, I'd be the first to accept it doesn't always work as well as it should, but actually having a good joint understanding of the needs of the person who is being discharged, and in this case has been delayed for whatever reason, such that when they do get discharged, plans are in place to support them to get the care they need once they're not in an acute environment anymore. We know all the evidence says that involvement of families and carers is crucial.
So involvement in families and carers, not just in planning that process, but also recognising the role that they very often, indeed perhaps generally, have in supporting and indeed delivering healthcare back at home.
Absolutely.
And so again, insofar as there was a mixed experience last time, looking forward to the next pandemic, should we get one, you presumably would encourage that best practice approach being adopted across the board?
Yes. I mean, as I was saying earlier on discharge, I think we did very much try and build on the best practice that was already in place in the NHS, and then encourage everywhere to adopt that way of working at pace. And absolutely, I think that is what we've done since then in a whole range of different ways. So whether it's elective recovery or it's tackling delayed handovers, certainly discharge, I would be seeking to do the same again, which is learn from where it's working well and then try and support that to become much more common practice across the NHS.
Thank you, Ms. Pritchard. Thank you, Lady.
Thank you, Mr. Wolfe. Mr. Stanton, he's behind you. Please make sure, though, that if you look at him when you ask the questions, that you turn the microphone. Thank you.
Good afternoon. I ask questions on behalf of the British Medical Association. I'd like to initially, if I may, pick up on an issue you were discussing with Ms. Carey, which is about whether enough is being done to support healthcare workers with their mental health and well-being. I just wondered if I could bring to your attention some data I'm sure you're aware of, but before the inquiry, Professor Fong has talked about the levels of severe depression in ICU staff, which he referred to at 52%. He also mentioned ICU staff, this is from a survey, around January 2021. ICU staff also experiencing severe anxiety, and 44% of staff experiencing that. And those figures are echoed by the inquiry's intensive care experts, who refer to 50% of staff meeting the criteria for a mental health disorder. And just against that backdrop, and obviously having regard to the issue that you've recognised, you referred to the fact that mental health and well-being was the #1 issue for staff absence. Do you think enough is being done within the NHS to support healthcare workers?
Thank you. Should I look back here when I'm answering?
Please don't feel free.
You've got to go into the microphone. So,
Yes,
yep.
I will. Sorry, it does feel a bit odd. So thank you. So is enough being done? I think one of the things that we start from is, again, that recognition of just what staff did during the pandemic and the extraordinary lengths that people went to try and support patients. And it does have both a short-term and long-term impact. So specifically for doctors, we do have a programme which is called the Practitioner Health Programme, it's actually not just for doctors, but it has been predominantly for doctors, so sorry, I should have just corrected that. That is something that we get incredibly positive feedback about, and last year there was a suggestion we might move away from it, but I was absolutely clear that would have been the wrong thing to do. So not only have we recommitted to that programme, but the review that's happening now is very much about saying, OK, well, if that's what best practice looks like, how do we make sure there's some learning about what we can do more broadly to make sure that all staff are accessing that kind of high-value support. But whatever is done nationally can only ever support what's done locally. So I think it's this importance of occupational health services and both being clear about what we're asking of them, but also what support is required, such that, I was very fortunate in my previous organisation, we had a superb occupational health service, which was, which I think really enabled staff to access support, which I know is not universally available. And that's the kind of thing I think this review that we're currently undertaking is seeking to understand and seeking to get a clearer view of what we could be doing in the future.
Thank you. I appreciate what you say about supporting employers at a local level to support their staff. I just wonder, given the levels of sickness and the figures that I brought to your attention, do you not think we're now at a point of crisis and that NHS England needs to take more of a lead in this area?
Do you mean crisis in relation to workforce mental health?
Yes.
Thank you. So our data at the moment tells us that sickness is running at a higher level than it was pre-pandemic, but it's only about 1% higher. So actually, if you translate that into numbers of staff, that's big numbers of staff, bearing in mind how many people work in the NHS. But I think it would be, it probably just, I absolutely respect what people are describing about their personal experiences and the level of pressure they feel under. I think our focus has been to say we can see that a proportion of those people are not able to continue to work, so hence the level of sickness increase. However, we can see that a lot of people are still finding that they can work, so how do we support them best to be able to continue to stay at work? So yes, I agree, NHS England should be seeking to lean into this, and hence the guidance and the review. But I also think that all our learning tells us that what really makes a difference is what's happening locally. So a good example would be flexible working arrangements. That's the kind of thing that we know, particularly if you've been off sick, you want to return to work, a graduated return to work programme is the kind of thing that can really make the difference. But that's not something that we can nationally do. That ultimately, we can give guidance, but it has to be done in discussion between a local employer and an individual to really work out what the right model is going to be for them.
Thank you. Just picking up on the point you mentioned there about support for healthcare workers returning. The expert report and oral evidence of Professors Breitling and Evans, who are the inquiry's experts in long COVID, made reference to the fact that flexible, individualised, phased returns appear to be better managed in the private sector. And they suggested that the NHS, as a large employer, has quite a fixed process. What do you think is needed for the NHS to provide the same level of support as in the private sector, and how can it improve?
So I suspect that there is, in fact, I know there is some very good practice in the NHS, and there are places that are aren't systematically adopting that best practice to the same extent. So one of the things that we did as part of the long-term workforce plan, which was a really big moment for the NHS, first time we've ever had a long-term workforce plan, but was to include in it the evidence from the, if you like, the sort of trailblazer sites that have been working on the retention programme. But the retention programme was actually a whole range of different initiatives, again, supported by NHS England, run locally, to try and put in place whole series of different things to help staff feel valued and appreciated, able to work in a way that worked for them with their work-life balance and other commitments, but also then retained them not just within the NHS, but also within that local organisation. And what we could see from that data was that really did make a difference. So retention rates higher, satisfaction higher, and that is something that we are now rolling out across the whole of the NHS. So to try and recognise that variation does exist, but that it is also quite a big ask and quite complicated to put in place that big package of staff support, which many trusts, as I say, do well, but for others, they've got more work to do to implement it. So that's the kind of thing where I would say recognise definitely that there is potential to do better on things like flexible working. It's really important, but we have I think now a way of approaching that more systematically to take the best practice that exists in some places and from the private sector, and to try and support that to be introduced in a much more systematic way across other organisations as well.
Thank you, Ms. Pritchard. Thank you, my lady.
Mr. Stanton. Very grateful. Mr. Kazani, he's over there.
Good afternoon, Ms. Pritchard. I ask questions on behalf of Mind, the mental health charity. The first topic I wish to ask you about, if I may, relates to planning. The children and young people's mental health inpatient experts appointed by the inquiry, Drs. Northover and Evans, say at page 41 of their report, in relation to planning, there is no evidence to suggest that the UK healthcare systems had specific plans for mental health inpatient services in the event of a pandemic, beyond those for all healthcare inpatient services. Prior to the COVID-19 pandemic, it does not appear that the UK's preparedness and response capabilities considered mental health illness, either adult, community, child, or inpatient. And then at para 164, they say pandemics can have a significant negative impact on child and adolescent mental health. The COVID-19 pandemic exposed young people to known risk factors for mental illness, such as disrupted schooling, social isolation, health anxiety, and economic instability. In that context, Ms. Pritchard, can I ask first, would you agree that the potential for a significant effect of a pandemic on the mental health of children and young people was foreseeable, and that NHS England had no specific plans for children and young people's mental health inpatient services in the event of a pandemic?
So was the impact foreseeable? I think I'd probably go back to every pandemic is different, and I don't think, to be fair, there was a plan existing across government or indeed in the NHS that specifically looked at, for example, the impact of school closures or the impact of that level of disruption on children and young people specifically. So in the context of the planning, I think we are back to there being the framework that then needs to be looked at in the context of whatever the specific thing is that you are actually facing at that time. I think there is, though, sort of two things, if I may. No doubt that actually the impact on children and young people has been profound, particularly from a mental health perspective, and that gives us sort of my third point. And my lady, I should have said this when I was given the opportunity earlier, so if I may just link them. My other big reflection is planning for recovery right from the start. So we now are in a place where we're still on a very significant recovery journey. I think that is absolutely the case for children and young people's mental health services and children and young people's services more broadly. But it is equally the case if I look at things like elective work, where, my lady, you mentioned the value of things like surgical hubs, elective centres, that ability to keep services separated such that they can keep going, but also quickly come back on stream, and where that is absolutely would be one of my standout recommendations conditions from an elective perspective, that would also be what I would come back to saying in a future pandemic plan, the importance of recovery covering mental health as well as covering physical health. I think I would be equally clear about the importance of that.
Thank you. Would you agree, Ms. Pritchard, that we now have sufficient evidence from the COVID pandemic to conclude that a pandemic and associated infection control measures are likely to, may well, whatever language you like, have a significant impact and a negative impact on children and young people's mental health, and that all future pandemic preparedness planning should now include the likely consequences for children and young people's mental health services?
Yes, I would agree.
Thank you. In a different context, in paragraph 248 of your first witness statement, you quote a briefing dated the 15th of November 2018, which was jointly published by the Health Foundation and the King's Fund and the Nuffield Trust, and it was about workforce challenges facing the health service. In relation to mental health, on page 11 of that briefing, it says, long-standing objectives to reach parity of esteem between physical and mental health will fail if the NHS cannot overcome the existing deep shortages in mental health staffing. In the 15 or so months to March 2020, can you assist on what progress was made in overcoming those deep shortages in mental health staffing, please?
On specifics, if I may, I'll come back to you because we will have exact data that I can share. I do know that over the period that we're discussing up till now, in the same way as we've seen increases in the number of staff that we now employ across the NHS, that has also been true for mental health, but it is still one of the areas where we experience the greatest staff shortages. And whilst we've seen, again, a very significant increase in the number of people with mental health conditions who've been able to access treatment, that has been far outstripped by demand, and that is both true for adults and for children and young people. And clearly, the provision of services is entirely dependent on people. So the ability not just to recruit and retain, but to train staff is been baked in to the work that my colleagues in the mental health team do nationally, right from the period you're talking about, was reinforced in the long-term workforce plan. As I say, I know we are continuing to make progress, but in terms of being able to give you exact figures, I will undertake to make sure we come back to you on that.
Thanks. Just to clarify one point, when you say far outstripped by demand, what period are you talking about?
So post-pandemic particularly, we have seen an increase in activity. I'm thinking particularly of your question about children and young people.
Yep.
But the level of demand, so new referrals into services, has gone up much more steeply. So that speaks to your point about the impact of the pandemic on children and people's mental health. But it is also, we've also seen a steep increase in demand for adult services, but it is particularly noticeable for children and young people.
Thank you. And just in relation to those difficulties created by asymmetries between demand and staffing capacity, supply in particular, would you agree that a lack of capacity on age-appropriate wards for children and young people, or local wards in children and young people's home area, increases the likelihood that a child or young person that is assessed as needing inpatient detention is going to be placed on age-inappropriate, in other words, adult wards, and or out of area, particularly during surges in demand, for example, during the pandemic?
Yeah, there's a lot in that question. So one of the things that we've been trying to do over recent years is obviously move to much more of a community-delivered model. And saying that, recognising there will likely always be a need for inpatient care for some people. So access to inpatient beds for children has been an issue for some places for some period of time.
Yeah.
I'm not aware of cases where children have been placed in adult mental health settings, but I am aware that we have, and there have been periods, I mean, even now, where we have children who are in acute beds, so they're in a physical health hospital bed, because they're waiting for a placement in a specialist mental health bed.
Yep.
And I think that is clearly an area where if you're then placed out of area, you've got a particular challenge about making sure that the appropriate family access, wraparound support is in place.
So I think we're moving beyond.
Oh, sorry, we are.
No, it's not your
My
fault.
apologies.
But I think we are moving beyond COVID-19. So thank you very much, Ms. President.
Thank you, my lady.
Ms. Hannett. Ms. Hannett's behind.
Right, I'm just getting the lectern. Apologies. Good afternoon, Ms. Pritchard. I ask questions on behalf of the long COVID groups. May I ask, please, by asking you a question about the data on the impact of long COVID on the workforce? You explain in your witness statement that the NHS workforce is its greatest asset, and the inquiry has heard evidence from multiple sources, including Professor Powers, of the ongoing and debilitating impact that long COVID has on the NHS workforce. We know from minutes from a long COVID oversight board meeting in October 2021, by that point, no specific data relating to workforce absences due to long COVID was identified. My question is NHS England collecting data now on the number of healthcare workers, both clinical and non-clinical, who are absent from work due to long COVID?
The simple answer to your question, I'm afraid, is no. But there is a process which is currently underway to re-procure the electronic staff record system, which I think does give us a chance to look at the sickness coding that is embedded in that system. They've committed, the team who are doing it, which is led by the BSA, but in partnership with NHS England and many others, to have wide stakeholder involvement in that process. So again, speaking personally rather than on behalf of the organisation, I think that is a very good and important opportunity for us to look at making sure we have got that coding in place.
Yes, because of course you said this morning that long COVID is really significant for both patients and staff. And would you accept that in order to understand the impact of long COVID on the NHS workforce and to ensure that there are adequate preventative and protective measures in place, you do need to collect that type of data?
Yes, I mean, so again, I'm very aware that this is an area where locally, if we asked every trust, I'm sure they would be able to, through their occupational health units, give us some very useful insight. But it does feel to me that is a fairly obvious thing for us to try and build into the next iteration of ESR, is an ability to collect that data more easily nationally.
Thank you, Ms. Pritchard. My next questions concern long COVID services. You wrote the foreword to the NHS priorities for 2022 to 2023, and that document recommends an increased number of patients be referred into long COVID services. Can I ask, please, what NHS England has done to improve rates of referral into the long COVID services?
Yes, so I know you talked to Professor Powers in some detail about long COVID services, which he's been championing for some time. But the way that planning guidance works is it is our, if you like, sort of in a non-pandemic context, it's the way that we would issue out to the NHS the priorities for the coming year and the expectations, if you like, that government has agreed with us that we're then translating into a set of operational actions for the NHS. So everything that goes into that is then followed up, sometimes very intensively by support teams on the ground, sometimes by data collection, sometimes by a mix of the two. So in this case, the long COVID sort of leadership team, or the team which have that in their portfolio, will be keeping routinely an eye on what is going on. And actually what they have said subsequently, I think you may have covered this, so forgive me if I'm covering the same territory, is that they have said there is variation in what they're seeing across the country. And without wishing to pass at the moment any judgment on what's behind that. Some of that might be good because some local services may well have developed a more sophisticated model that we would want to learn from and spread. Actually, some of it might not be. So there is a stock take going on at the moment, looking at what is happening across all of those long COVID services.
Thank you. And related, what has NHS England done to increase public awareness of the availability of long COVID services?
So I suspect that is, without, again, having the absolute data in front of me, something that we wouldn't really do as a national step. If it's about local services and local service access, that would be done by local commissioning teams working in partnership with providers to make sure that however they're communicating to their local populations and patients, is, as well as, of course, GPs and others who might be referring into the service, is sufficiently clear.
And would the stock take you've just referred to be a good opportunity to check that local long COVID services are communicating their existence appropriately to their local population?
That seems like a very good idea.
Turning then in terms of analysing the data from long COVID services, in Wales, the Ad Feriat reports are published every 6 months, give an analysed narrative picture of long COVID patients. And they analyse, for example, their ethnic and social demographics, impact of long COVID on their general quality of life. Do you agree that a regular, detailed, analysed picture of the data from long COVID services would assist NHS England in improving its long COVID healthcare?
It might. I think we would need to just look at what that data is then used for and how that then feeds into future commissioning or future commissioning arrangements or plans for provision. I'm conscious that we do run a range of national audits within England, and it may well be that that's something that would be better seen as, as part of that more structured audit programme. But I don't know enough about how they do it in Wales, probably to be able to say exactly what model would work best. I mean, certainly looking at the data, we have teams at NHS England, Professor Powers overseas, who do that and who are currently doing the stock take, and I'm certainly happy to say, to pass back that might be a question again that we could ask that team to pick up as part of their work.
Yes, it's the regularity and the qualitative aspect of it that's of concern to my clients, certainly. But I'm grateful. Thank you, Ms. Bishop. Thank you, my lady.
Thank you, Ms. Hennett. Mr. Thomas. Mr. Thomas is over there behind you again, I'm afraid.
Good afternoon, Ms. Pritchard. I represent FEMAHO, the Federation of Ethnic Minority Healthcare Organisations. In paragraph 164C of your statement, you mention that NHS England's Chief People Officer convened national meetings with Black, Asian and minority and ethnic staff network leads and EDI leads across the NHS after observing the disproportionate impact of COVID on these communities. Would you say that this engagement was a reactive measure to the disproportionately high death rates, or was it part of a pre-existing strategic intervention aimed at supporting ethnic minority staff? And if the latter, if you're saying it was pre-existing, when were these meetings planned?
So I believe that this particular meeting was part of the work of the the cell that had been set up following a meeting which I think Lord Stevens had earlier in April, which had then led to him commissioning the Chief People Officer to lead some work, which I think then meant that meeting you've referred to, I think, as you say, is the 30th of April, was then part of the action that was taken by her in her capacity leading the cell. So I think that's as a specific action was part of that work. But she was already leading for NHS England on staff inequalities, so things like the race equality scheme the disability scheme, and a whole range of other actions and activities that were taken nationally were already part of whole portfolio. So in her job that wasn't pandemic related, she would have been in regular contact with leaders from staff networks, not just race, but more broadly as well.
Let's stay on leadership representation. Would you agree that having more Black, Asian and minority ethnic leaders in senior NHS positions would probably have influenced the response to the adverse outcomes experienced by ethnic minority healthcare workers?
I don't know is the honest answer to that. In my National Incident Response Board, we had an eye right from the beginning about making sure we had diverse representation, so not just overly clinically represented, but making sure that we were bringing into the room that inequalities lens, staff inequalities as well as patient inequalities lens. Do I think that made a difference in the response? There are multiple factors, including, I think, the speed with which it was spotted that there was that disproportionate impact. And my sense is that certainly Lord Stevens was very responsive once he was made, once it was drawn to his attention. He was the chief executive at the time in taking action. As a broader point, though, we absolutely see the importance of lead representative and diverse leadership within local bodies as well as national bodies, and would thoroughly support that. In fact, that is one of the high impact actions that is in our Equality and Diversity Action Plan that was published recently.
Well, can I piggyback on what you've just said? How could leadership diversity accelerate critical interventions to protect these workers? And can you suggest specific measures to support a pipeline for ethnic minority leaders within the NHS?
Sorry, I've realised I'm looking in the wrong direction, so I'm going to turn
You're
back
still
to look over
speaking
here.
into the microphone.
Apologies.
No, there's a microphone to your right, so it's
Okay,
not,
fine.
you could probably
You're being picked up.
So fine. Okay, in that case, I'll carry on looking this way. So there is a. So I think you've perhaps answered, tell me if I've misunderstood the question, but there
Do you
are
want me to repeat the question?
two parts. So one of your questions, one part I think is pandemic specific, and then one part is sort of future focused. So in terms of the pandemic, one of the things that we heard pretty clearly in that summer period in 2020 was that the risk assessment process was both too slow and in some cases not resulting in the follow-through that was necessary to respond to the things that have been identified in the risk assessments. So again, I don't think I could say whether more diverse leadership would have made the difference or not. We haven't done enough systematic analysis of where was doing it well and where wasn't, but there was certainly a need for, I think, us from a national perspective to make sure that we were both very clear about the importance of that risk assessment process, but also that we had provided the right guidance and follow through on what a good process looked like. So in the end, we actually set up a unit nationally, again under the Chief People Officer's leadership, to really support and get stuck in for places that seem to be finding it more difficult to do. And that did lead to, I think, significant improvement in certainly the number of risk assessments that were undertaken. On your point about sort of future pipeline, I'm sort of, I suppose, both pre-pandemic, during the pandemic and subsequently, we have a lot of different work going on around equality, diversity, inclusion in the NHS, but one of those specific themes is around leadership and the pipeline developing future leaders. So the talent management programmes that exist in the NHS at the moment are oriented in that direction. Certainly if we think about things like the aspiring chief executive programmes, that's one of the things that's explicitly considered. And indeed, as I say, it's something that I've certainly given a lot of thought to personally. But the high impact actions that are set out in our Equality Diversity Action Plan, they are about making things different in a very practical way, and that's the set of things that I signed up to along with our current lead for workforce training and education as being the important things that we are expecting, not just our own organisation, but the whole of the NHS in England to adopt and to deliver.
Right. I want to move on because I'm conscious of time. I want to turn to timeliness of data collection. Can we agree this? Can we agree that if ethnic-specific data had been collated and collected sooner, NHS leadership might have been able to respond more swiftly, differently, systematically to protect minority ethnic healthcare workers? Can we agree on that?
In what regard? Do you mean in relation to staff deaths?
Yes, and not just staff deaths, in terms of the impact of COVID on staff, whether that be illnesses or death.
So I think we moved really quite quickly. I know we've talked about it already, to stand up new data collections because they did have to be new, partly because we still don't have, it's much better now and needs to continue to develop systems that allow us to collate local data into a national view at speed. I think that will be one of the things, again, I've already said, I think for a future pandemic that will be really useful. But the early indication that there was disproportionate impact on certain groups, actually the initial thinking I know from scientists and from the medical profession was pointing towards older people and people with significant underlying health conditions, including, for example, diabetes. So I think it's probably fair to say that the data originally pointed in that direction, and then it was a few weeks later that it became clearer that actually there was a real signal in the data. I don't think that was so much though from staff data. I think that was coming more from the overall population data that was suggesting there was a disproportionate impact on people from Black, Asian or ethnic minorities.
Yeah, short point though. When that data was coming through, the NHS moves a little slow. Would you not agree?
Well, I think Simon Stevens' meeting was the 15th of April. So if we think about the sort of speed with which this was all happening, the cell, I think, was set up the following day, and then there's a whole set of actions that follow from it. So we had both, I think, written into the 29th of April letter that expectation of risk assessment and a clear signal about the fact that the data was now saying that there looked like there was a disproportionate impact. And we then had not quite right, but we had another programme of work that was looking at the disproportionate impact on patients and on communities, also then feeding into a whole set of actions that were written into future asks of the NHS to adapt services to make sure it was responsive.
A couple more questions. I want to take these swiftly, if I may. When data on ethnicity had begun to be gathered, how was this data used in NHS performance monitoring and response efforts during the pandemic? And would you agree it made a difference when you started to use the data?
Do you mean in relation to risk assessment?
Yes, and the impact of the virus on ethnic minority groups.
So, yeah, what the point... So, I mean, I think I've perhaps already covered this a little bit, but just when it became clear, as I say, that we needed to ensure that risk assessment was taking place, it was slower to get off the ground from that sort of April the 29th period, and then we write again, I think, on the 24th of June, and then there's the unit set up at the beginning of the 5th of July to help support the delivery of risk assessment across the NHS, and it, looking at the compliance rate, it does get much better after July, but it has taken, I think we would all accept, too long to get that in place. So certainly I think it was a learning point for the future, is that as soon as data becomes available that tells us which particular new version of a pandemic is going to, what's it going to do, then the ability to react at pace and to have systems, data systems around that's really important.
I think we're agreed on this. Let me come on to. I'm nearly there. You refer to socioeconomic factors and the role of multi-generational households in certain regions as contributing to higher COVID rates among ethnic minorities. How were these additional risk factors captured in the NHS data collection efforts?
I don't think there was a mechanism of capture capturing that data. What we did do was look at deprivation data, which isn't a direct, it's not it's a proxy, it can't give you the whole story. But we were certainly seeing across the NHS that those people who lived in more deprived communities, where there isn't a direct, but there can be a correlation with then poorer housing stock, but also with, actually we should be clear, urban areas as well. So there were other bits of data that were becoming available that were certainly giving a sense of where the greatest risks seem to lie.
Finally, this, and I'm just trying to wrap up, and I want to be forward-thinking for the inquiry. Given the disproportionate impact of COVID on ethnic minority workers and recognising historic and structural challenges they face, would you agree that this experience has underscored the need for deeper structural changes within the NHS to address long-standing inequalities? Would you agree with that?
I absolutely agree that we need to continue to do... do you know what? Let me start again. I agree we need to do more.
All right.
And it has never, I think, been highlighted as obviously as through COVID, the importance of the contribution all of our staff make to the NHS and our absolute reliance on the people who do every job. I haven't talked about it today, but the work of our engineering teams, the work of our estates teams, the work of our porters, and But the point for me is simple. If you work for the NHS, you have to feel fully valued by the NHS, and we need to do more.
Yeah, I understand it, Ms. Pritchard, but the point is, those who were disproportionately impacted. That was the focus of my question. And minority ethnic healthcare workers were disproportionately impacted. That's the point.
Yes, and I suppose what I'm responding to is just a recognition that all of our, well, you could argue, taking the opportunity to say it, because I don't feel I have yet, but just to make sure that we don't only talk about doctors and nurses when we talk about the thing that colleagues did through the pandemic, but also acknowledging that actually making sure that as an employer we are embracing what is a huge strength, which is the diversity of our workforce, but also recognising that actually the experience of our workforce is not uniform in different places, in different roles, but also where you have particular issues that we must address for those
Thank you,
colleagues.
Mr. Thomas.
Related to race.
Thank you, Marie.
It's getting pretty late. I'm sure it's feeling pretty late for you, but it's just that they have limited time.
Sorry.
The advocates have sometimes quite very restricted time. So if you could keep your answers short, I know they'd be very grateful.
Sorry.
They don't like me jumping in. Mr. Jacobs.
Ms. Pritchard, some questions on behalf of the Trades Union Congress on a similar theme to Mr. Thomas. Questions on the position of those healthcare workers who work in outsourced services. Does NHS England hold data on the proportion of staff in outsourced services who belong to Black, Asian and minority ethnic groups?
We don't hold data on outsourced staff.
Does it not need to in order to consider the potentially significant equality implications of commissioning services in that way?
So we don't actually hold data. When I say we don't hold data, I mean we don't hold any data on staff who are employed by third-party outsourced providers. So the way that it works at the moment is NHS England, as the sort of overarching commissioner, passes resource down through what were CCGs, are now ICBs, to local employers who then determine how they spend it. So the responsibility sits with the local employer, so if that's the trust, to make sure that then in their contract management, if you like, with the provider of, it's often hard or soft facilities management services, that they are then working with that provider to ensure that the appropriate data, but also the appropriate
So that's at a lower level. So do we take it from your answer that NHS England actually doesn't see itself as having a role in terms of considering the equality implications of delivering some healthcare services through outsourced services?
So I think just to be clear, I guess what I'm saying is we collect data on people who are NHS employees, but that by its very nature, is never going to be a full picture of all of the colleagues across the country who are
the question. I think that's an answer to a different question.
Services.
The question is: does NHS England consider that it has a role in considering the equality implications of delivering certain healthcare services through outsourced services?
So we have an overall, I mean, there are a set of things we are responsible for, including quality. Well, actually, we're not the quality monitor, that's the CQC. But there are a set of things that NHS England is responsible for in commissioning, and then the follow through to ensure that the commissioning is being done well and services are being provided as per expectations. So if a local employer has chosen to outsource a service, they're still responsible for the quality of the provision of that service.
If I understand correctly, your answer is that the
monitor
local employer is responsible for considering equality implications, not NHS England.
Well, but not in a different sense than in a sense for any other. So we're not responsible for the provision of community pharmacy services or optometry services, and nor are we responsible for the provision of services by voluntary sector partners. But we are responsible for setting standards that we then expect to be delivered through whether it's a contract mechanism or it's a direct employment mechanism.
Yeah. The inquiry has heard evidence from those, for example, who talk about the importance of reducing precariousness of work and reducing inequality of impact. My client and others are concerned about working conditions in outsourced services that may compound some pre-existing inequalities. The inquiry has heard accounts of workers having less access to sick pay, being less able to raise concerns, lower priority for PPE, and so on. Does NHS England share a concern that the conditions of those in outsourced work is such as to compound pre-existing inequalities?
So I have personal experience of working in trusts with outsourced providers and insourced. And what I can say is they can both work really well and they can both work less well. So where a trust takes its responsibilities for working in partnership with, but through a contractual arrangement with an outsourced provider, and as where I used to work, which was not Guy's and Thomas's, somewhere else, did, and that leadership team is part of the trust leadership team, that it is absolutely, staff are treated exactly as if they were members of the NHS workforce, because they are, in practice, of course, members of that wider NHS family. It can work really well, and actually can work, I could argue even better sometimes than the NHS trying to do it for itself, because you often have people who have real genuine expertise in running those services and can be much more responsive to the needs of their staff. Equally, it can work badly. So if your question is, which I don't know if it is, but it's something I've reflected.
Well, let me ask a follow-up question.
Yes,
we have your personal experience that it can work well, it can work badly. We've certainly had personal experiences before the inquiry of it working badly. Does NHS England not need to do some work, particularly with this concern about disproportionate impact, on truly looking at this issue and trying to understand it and trying to understand whether this is one area in which there needs to be some change?
So thank you for the question, and I have thought about this because I read the evidence given by previous witnesses on it, and on reflection, I do think we should have been clearer about the expectation that everything that we were pushing out as guidance or as asks of into the NHS, we should have been explicitly clearer that needed to apply to outsourced staff. So thinking about, say, risk assessment, I now think we had taken the normal way of working as being the normal way of working, and actually in a pandemic situation, there's probably a need for greater clarity of expectations, and that would be one of the points of learning I would take into a future pandemic.
And just finally, you said a moment ago, if you work for the NHS, you need to feel fully valued. Is NHS England confident that outsourced healthcare workers feel fully valued?
Well, so I am not confident at the moment that we are doing collectively as the NHS, as I've just said to your colleague, enough to ensure that all our staff feel equally valued. So again, I don't want to inappropriately suggest that's something that NHS England can fix, because ultimately it has to be for local employers to lead. But can we support both in relation to NHS, people on NHS contracts, and with clear expectations about outsourced staff? I think we can.
Thank you. Thank you, Milady.
Thank you, Mr. Jacobs. Mr. Stone, I'm sorry you come at the very end of a long day. It'd be grateful if you could focus on the main issues you wish to highlight.
Milady, yes, I'm conscious of the time.
Thank you.
Good afternoon, Ms Pritchard. I ask questions on behalf of COVID-bereaved Families for Justice UK. And two short topics, if I may, please. The first relates to discharge from hospital during the pandemic. You told us about the steps taken to promote discharge of medically fit patients during the course of the pandemic for reasons you explained and that we understand. It's an obvious point, but it needs to be appropriate discharge because of the risks to patients associated with inappropriate discharge. Can you tell us what additional measures NHS England introduced to ensure that the risk of inappropriate discharge was addressed, including monitoring and evaluation of discharge processes?
Yes, you're completely right to say that it must be appropriate discharge. So I think probably worth saying that's why the guidance, which I think the Department of Health led on, but we were absolutely co-signatories to, was very clear about the expectations around what good discharge would look like, and it was based on, as I said earlier, the sort of existing best practice, but with an expectation that that would then be something that would be both enabled by those policy decisions that have been made, but implemented locally. And one of the things that I think we were, again, very clear about was this was focused not on people who had any medical reason to still be in hospital, but only those people who were medically fit to leave, so shouldn't have been needing to be in an acute environment. The follow-up on quality was a couple of things. So there was monitoring going on through our National Incident Response Board, through very regular feedback on numbers, but also feeding in the experience that was being relayed to us by partners in local government, by experience of local ICBs and trusts feeding back, but also, and this is sort of the final bit of it, we were looking at readmission data, which is only a crude tool because obviously, bearing in mind there are loads of other factors that can affect readmission. I wouldn't want to over-rely on it, but that did show over the period that readmission rates went up by 1%. What we couldn't do is disaggregate from that how much of that was people catching COVID or other things going on that meant that they came back. But it was nonetheless just a sort of helpful additional piece of data to allow us to just keep an eye on whether or not this was leading to unintended consequences about people then needing to come back into hospital.
And was there official review of that question, that exact question, i.e., are there unintended consequences? On
readmission rates? Well, as I say...
Just generally, are there unintended consequences of this, of the enhanced focus on discharge?
I'm not aware I'm sure there is, but I'm not aware of any specific research that's been done, sort of third-party research on this. We produced within NHS England our sort of own analysis of what had happened and did a learning report, which I referred to earlier, which was one of the things that led to that conclusion about the number of beds, staff, and also that had been released through the measure, but also the feedback about the discharge to assess model being the one that was preferred from both social care colleagues and also from the feedback that we were getting from the Frontline. But I suspect there are more independent sources of research which I'm not familiar with.
And I think the report that you referred to earlier, you've just re-referred to it, that didn't specifically address, I don't think, correct me if I'm wrong, the question of inappropriate discharge.
Not on a sort of individual. Do you mean on an individual patient? What? Sorry.
Well, did you, NHS England, look at whether there was any adverse outcome, unintended outcome, I can't remember the phrase that you used, arising from the focus on discharge, and specifically inappropriate discharge arising from that focus.
Right. Okay, so not in the sense that we were explicitly, I think, looking at. So we didn't do any work to say were people who were not medically fit for discharge discharged, and all of our analysis was based on, if you like, the local analysis, which categorised patients as being medically fit for discharge.
Yeah.
So I don't think there was an audit done of whether that categorisation was appropriate. But of that group that were medically fit for discharge, that's where so that is the bit that we then, our analysis was based on, I suppose, that initial categorisation being appropriate.
And are you aware whether concerns have been raised with NHS England about the emphasis on discharge leading to inappropriate discharge?
We didn't have concerns raised, to my knowledge, I should say.
Second topic, please, is the EPRR framework that you've referred to.
I'm so sorry. I should have just said I'm conscious that we're not talking about discharge to care homes at this point, though, are we? Because clearly there's a whole set of conversations about discharge to care homes. So if you're asking about...
Yes, so there'd be specific concerns, and I think that the inquiry is well aware of about
exactly.
discharge.
That's a different one.
Good,
Right.
fine. That's just, so I'm conscious I haven't answered that question. I was asking a slightly different question.
Inappropriate in broad terms is what I was referring to for the purpose of that question. Moving on then to the EPRR framework, please. You've told us that it's recently been updated this year. I just wanted to ask you about one aspect you refer to in your statement, and that's health inequalities, please. At paragraph 182 of your second statement, you note, Ms Pritchard, that the EPRR framework has been updated to confirm that specific guidance on managing health inequalities during a major incident is being developed and will be published in due course. So do we infer from that that specific guidance did not exist as we went into the pandemic?
That is correct. There wasn't specific guidance on health inequalities. I know you want to move on, but can I just, for the record, because I'm conscious this is formal, say when I said there were not concerns raised about discharge, to my knowledge, I am talking about discharge to assess, so that is not including care home discharge, where I think there is I know a whole separate module that will focus on that amongst other things.
So just so that we're clear, your evidence is that to your knowledge there were no concerns raised about discharge to assess
not as a policy
during the pandemic, is that correct?
There were definitely and continue to be individual examples of where discharge did not go as well as it should do. But in terms of a concern about that policy being moved to, that wasn't something that was raised.
But there were concerns raised about examples of discharge that didn't go as it should have done, which we might refer to as an inappropriate discharge.
I think there were there were examples. I'm actually not sure I would use inappropriate, but what I would say is there were certainly examples of where things like communication wasn't quite good enough, or people felt that they weren't, quite clear about exactly what the arrangements were for who was going to come in to provide what care when. I mean, not outside the, I hate to say it, but sort of not outside the usual type of things that can not go as well as we would want them to from a discharge perspective. And certainly the speed with which some of the discharges were, they were medically fit, they were delayed, they were expecting to leave hospital, but perhaps not quite as fast as they had previously thought. And I think that no doubt did create some pressure on the system. So I'm drawing a distinction between the sort of concerns about the policy, individual examples where, clearly things, even today, don't always go as smoothly as we would want, and then a specific set of issues around care homes, which we haven't really talked about today.
No. I think that's understood, Ms Pritchard. Just coming back, please, to the EPRR framework.
Sorry. Oh, yes. So no, there wasn't a specific.
That didn't exist as we went into the pandemic. Given that the scale and severity of health inequalities in the UK as a whole, and England in particular, were well known, as was the likelihood of those inequalities being exacerbated in a major incident, and particularly a pandemic. Shouldn't that specific guidance have already been in place as we went into the COVID pandemic in 2020?
Yeah, I think I'm sort of back to what I feel like, apologies, but sort of said a couple of times, which is just, so the EPR framework is effectively a sort of set of action cards of things to think about. And then it's adapted to the specific circumstances. So there was a huge amount of work going on pre-pandemic about reducing healthcare inequalities. It's written into the long-term plan published in 2019, and there's a number of very specific programmes as well as a general focus. And in fact, where we are now with the creation of ICBs and ICSs is actually at the very heart of that. That way of working is the partnership between local government, the NHS, voluntary sector, patients themselves, in order to address healthcare inequalities amongst a range of other things. So should there have been a specific EPR framework that addressed healthcare inequalities, well, I think that is definitely one of the bits of learning from the pandemic, which means we will now have one in the future. But it was, I think, something that, again, we've talked before about a flu, the planning was based largely on a flu pandemic in the past, and I think those shortcomings have been identified through previous modules.
I'm afraid it's not your fault, Ms Stone. We're going to have to leave it there. But given that I've given you permission for the questions, if any of the questions that you haven't had the time to ask are ones upon which you'd like an answer, we'll ask Ms Pritchard to give us a written answer.
I'd be grateful for that opportunity. Thank you, my lady.
Thank you. I think that completes then the questioning. I'm sorry it's been such a long day for you. I don't know if you realise that the team at NHS who've been helping us, this is statements from you and Sir Stephen. You probably saw me refer to them this morning. Anyway, thank you. I don't know how much you have been involved in getting the team together to answer all our questions and to provide help to the inquiry, but I'm very grateful for all that your team have done and obviously that you have done too.
Thank you.
Thank you for your help. Very well. 10 o'clock tomorrow, please.
All rise.